I will just go ahead and start now and let people come in as they arrive. Thank you for joining us tonight. Welcome to our lecture series. My name is Renee Westmacott, and I'm your host for the evening. Again, thank you so much for joining us tonight. Tonight's lecture is the third in Ellen's six-part pelvic floor lecture series titled The Pelvic Floor and the Lower Back. Learn more about this love-hate relationship. I'm excited to introduce Mrs. Ellen Wedemire, formerly known as Rossiter. You'll see that change on the website very soon. Ellen has been with AST for many years, starting out long ago as a clinic assistant, and now Ellen is one of our expert physiotherapists. If this is your first time listening in on the pelvic floor series, I promise you will not be disappointed with Ellen's clear and detailed explanation of all pelvic floor matters. If you've been with us all along, thank you. Thank you for coming every month. We are halfway through the series and look forward to seeing you throughout. Now, I will do a little bit of housekeeping. If you have any questions during the lecture, feel free to write them into the chat box. I will be keeping my eye on them and watching. If the questions are relevant to the moment, I will interrupt and ask them for you. On that, having said that, anything pelvic floor related is a potentially sensitive subject, and you may prefer to ask in a private way. We completely understand, and there is a way to change your name on Zoom. Ellen will share this with you in the intro. Furthermore, when the lecture is over, feel free to stay on the call and ask any further questions. Please join me this evening in welcoming Mrs. Ellen Wedemire. Thank you, Ellen.
Thanks, Renee.
Yes.
Lovely. Okay, I'm just gonna share my screen here and we'll get going. All right. Perfect. So again, thank you so much, everyone. I was really excited to see lots of interest in this talk because it really kind of combines the two areas of physio that I just absolutely adore. So I am both a pelvic floor physio at Active Sports Therapy, and I'm also an orthopedic physio. So basically your injuries, your stereotypical physio, where I tend to see a lot of low back pain, and in pelvic floor where I tend to see a lot of kind of incontinence, prolapse, that kind of thing. So it was really exciting for me to be able to mash up the two of them. So thank you for being here. As Renee said, I absolutely love questions and I welcome them at any time. The chat box is a lovely way to do it so that I can kind of keep going, and then Renee is going to monitor that for me. Now, if we do want to remain anonymous, perfectly understandable, especially if we're talking about incontinence or a personal kind of question. The way that we can change the screen, at least when you're on a computer, is if you look at kind of your box at the top right corner, if you scroll over, there's going to be 3 dots. If you click on that, then there's going to be just a little screen name option. So feel free, you can change that to anonymous, you can change that to Jim, you can kind of say whatever it is. That name will show up on the chat box. So no one has to know who's asking those questions if you want to remain anonymous. If you don't, then that's also lovely. And then, like Renee mentioned, at the end, that would be also a really good time. So we'll try to stay on in enough time for people to ask away. All right, so we'll get going with our relationship between the pelvic floor and the low back. So number one, why do we care about back pain? I think that that's a question that most people don't really have to ask because 80% of us have already or will experience back pain in their lifetime. It is an incredibly, incredibly common issue in today's day and age. And generally it is recurrent or persistent. So it's not like, I don't know, a knee injury where you twisted it funny and then you resolve it and it's good to go. For most people, it'll be good and then it'll be bad for a little bit and then it'll go away for a year or two and then the exact same pain will come up. So we call that a persistent pain issue. So definitely something that we care about and why we want to kind of find ways to resolve it. Now, a reason that us in the healthcare field care about back pain so much is also that a lot of people end up getting imaging. Now, a lot of back pain imaging is great. So imaging being x-rays, MRIs, whatever. But some of it, it's not actually necessary. And if we can pull the patients out that don't need imaging, then the ones that need it, there's going to be less line. And I'm sure any of you who have been in line for an MRI know that it's a long time. So if we can kind of get things sorted out in the rehab world, then we want to pull you out. So that's why we especially care about back pain and back pain patients. Now, the reason that everyone cares is it affects your life so much. Back pain is one of those things that can affect work, especially either if you sit at a desk all day and your back hurts, it's really hard to focus, but also if you lift or move or whatever at work. And home life, that's a big one. Is oftentimes when I see people, they were dealing with it, they were pushing through in workouts, they were getting through their workday, but all of a sudden they can't lift up their child, or they can't hang out with their family comfortably. And that's a problem. So why do we care about back pain? It's because it's affecting you. And that's why we care so much, so we can get it sorted. Now, the reason I was so excited for this presentation is back pain is the reason that most people get connected with any clinic, especially our clinic. You might see the chiros or the physios or the massage therapists because of these persistent issues. So I am so excited to kind of teach you guys a small part of back pain that most of us don't really know. Now, there are so many different reasons for low back pain, and I don't want this presentation to make it seem like everyone with low back pain is going to be involved in this specific scenario. So we have sprains and strains. Maybe you twisted funny, or you were playing sports and moved in a weird way, and now you strained your muscle. There's disc herniation, which is often referred to as a bulge disc or a slipped disc, but basically it's where the disc is not exactly, it's kind of poofed out a little bit and could be impacting the nerves. On that note, we can have nerve injury or irritation. So a lot of times if you have back pain that's going down the leg, that's generally a nerve relationship. We can have facet joint or SI joint irritation. Your facet joints, you can see my little mouse here, are the little joints on the side of the spine, as opposed to those big joints where the vertebrae are stacked. And sometimes if they get irritated, it can irritate nerves, and it can be quite the conundrum. And then we also have SI joint irritation down where the sacrum, which is the bottom of our spine, meets the pelvis. We can have osteoarthritis, which many, many people have heard of and are experiencing, which is the arthritis that we talk about as skipped spinal stenosis, which is basically where if we have our nerve, we have our circle around the nerve of bone, especially coming down like spinal cord and where the spinal cord little nerves are coming out. And sometimes that can narrow a little bit. That's a stenosis. And trauma. So, you know, those big car accidents, athletic accidents, just general awful workplace related accidents where it could be fractures, dislocations. So those are all absolutely causes of low back pain. What we're going to focus on is our repetitive use or compensatory low back pain. So we're looking at those muscles that are taking over when they don't necessarily have to. So if we go into the low back has a lot going on. It has muscles galore, tendons galore, ligaments everywhere. It's very closely related to the hip. This is kind of where the glutes are coming and attaching. So you can see there's really close crossover here. We have our shoulder muscles that are coming down, attaching to some back muscles. Like everything is so interconnected. And these are just the superficial version. So if we were to just do a low back, like we could do probably a daily lecture for 3 months just to teach you all of the details of the back. But the ones that we are going to care about today are deeper muscles and kind of more specific muscles. So we're going to look at the QL, which is over here, quadratus lumborum. So it's sneaking under these muscles, but on this side you can see it. It attaches onto the pelvis, top of the pelvis, and then onto our lowest rib. And it is responsible for a bunch of stuff. We'll talk about that in a moment. We also have our multifidus, which are tiny little muscles between each little kind of segment of the spine. And then we have our erector spinae, which are long muscles coming down. And they're the ones that sometimes can kind of look like rods along the spine if they get super, super tight. So those are the big muscles that I'm talking about when I'm talking about the low back muscles kind of compensating or being involved. That's more QL and erectors. The multifidus is what we'll be talking about when we get into our core. So just kind of giving you a little bit of background before we get into the meat. So back muscle compensation. When we look at compensation and muscles that are tightening in the back, we're usually looking at the QL as well as those erectors that I was talking about. So the QL is supposed to have multiple functions. If one of them is working, it'll flex us sideways. If one of them is working, it might also hike the hip. So if we look at this one, so if we're stabilizing here and we're pulling down, then we're going to end up going to the side. If we're stabilizing here and we're pulling on that muscle, then it's going to hike that hip up. And then if both of them are working at the same time, it's going to extend us. So he already has a lot of jobs to do. And we want that muscle to just be able to focus on that job. But the QL is like the superhero that loves to swoop in and take over if anyone else isn't doing their job. So a lot of times we'll see if the hips are tight or weak or just not working properly, then the QL will come in and take over and try to move you. If the pelvis is not moving properly or it's moving too much, then it might come in and try to stabilize the area or try to kind of overcompensate and move us in a different way. And most important to us today in this lecture, if the core is not being used appropriately, then instead of using our core to stabilize, the QL is going to come in. It's going to try to keep us upright. It's going to try to stabilize before we move. And then if it's already doing all of these things, and then all of a sudden it's taking over and trying to do all of these things, it is going to get overworked and underpaid. And that is generally where we will see back pain. So many patients in the clinic, as you can see in this little note at the bottom, will come in with a very tight back because of a combination of a bunch of those things. So as I start talking about the core, I want everyone to remember that most of our bodies are incredibly complex. And I'm just kind of focusing on one area, but there's a whole bunch of other reasons that could be contributing as well. So let's talk about the core. Now, there's often, I guess, debate about what the core is and what you should call it. And so I will generally refer to it as the core canister or the central stability complex. So if I'm saying either of those things, that means the core that you're thinking of. Other people also call it the deep core, which again is at least a little bit more appropriate or accurate than the six pack. When we talk about core as rehab professionals, we are never talking about your abs that look awesome. Those guys are superficial, and we can see that here. So these are your six-pack muscles. They're called rectus abdominis. And if they are super strong, then they're going to show and you're going to look great, but they're not actually that helpful for stabilizing us, which is what most of our abdomen is for. These guys are pretty much exclusively responsible for pulling us forward, which is why when we do crunches, they get a little bit stronger. But what we care about are the deeper muscles. So you can see if we pull back that rectus abdominis, we're going to start seeing our internal oblique, and then underneath is our transverse abdominis. Deep abdominal muscles, all you really need to know it as. But it is super important, and it's going to be part of the canister that we'll talk about. So when I'm talking about the core, I never want you to think of, oh my gosh, I have to do 1,000,000 crunches or sit-ups. That is not going to help in stabilizing so that our back doesn't act up. All right, so the core canister. And any patient of mine, I saw a few of you popping up, you've heard about this before because I pretty much preach it to everyone, but we want to think of the core as a canister that's round or like a pop can. So the top of it is going to be your diaphragm. Your diaphragm is a breathing muscle that sits kind of, if I raise up, kind of under our ribs in a little arch that you can see in this picture. And it is responsible for dropping down in order to change pressures in the trunk so that the lungs will expand and fill with air. Then on the bottom, we have our pelvic floor, which we'll get into because that's my favorite. On the front, we're going to have that transverse abdominis muscle. So that nice deep muscle that's hanging out under everything. you can see in this picture, after we pull everything back, it's kind of like a corset. We call it the corset muscle because it is basically surrounding everything. It is the sides and the front of your abdomen. And then in the back, we have those multifidi, the multifidus muscles that we saw in the previous picture right here that are basically crossing little segments of the spine. So those 4 muscles or muscle groups are going to come together and create a nice canister that's going to create the appropriate pressure. So the bottom of the canister is the pelvic floor, and I can talk about it forever. I already have in multiple lectures, so I'm not going to get into it too thoroughly, but it's important that everyone knows what's going on down there before we continue. So the pelvic floor has a lot of muscles, a lot of tissue, ligaments, tendons, and we can see that here. Everyone is running in different directions and has a lot of different responsibilities, but they all come together basically to achieve 5 functions. So we have support for the pelvis and the organs. Important to think of, so this is a female pelvis. So we have our urethral and vaginal opening is going to be here, and then this is our rectal opening here. We have all of these muscles that are going and supporting different parts of the pelvis itself, as well as the organ. So if this is our vaginal opening, we have our uterus is right above it. We also have our bladder that's right above, kind of in that similar area. And then we have our intestines that are coming down into that rectal opening. So we have the muscles that are all trying to support them. We also have the sexual aspect of the pelvic floor. So again, the vagina is right there. We have muscles that are directly related to the clitoris. We have muscles that are going to help with penile and scrotal movements as well. So we have a strong sexual component. Stability, again, we are stabilizing so many different areas. There's a lot of joints. We have our pubic symphysis, which is right up front. Ladies who have given birth, especially vaginally, that actually, this little bit right here disintegrates when we're giving birth, which is wild. And it actually opens up so that baby has a little bit more space. But that means that that's a joint. It's not completely solid. So we have the muscles in there that are helping to stabilize through there. Same with our SI joint, which is right through here. It's where our sacrum and our pelvis are meeting. SI is sacral and ilial or ischial. And then we have a whole bunch of other joints involving the back and the hips. One of the hip muscles can only be felt internally with the pelvic floor. So a lot of really strong relationships there. We have the sump pump function because we have a lot of blood that goes through there, a lot of lymphatic fluid that's going through there. So those little muscles, as long as they are contracting every once in a while, are actually helping the fluid move, which is pretty cool. And most importantly for today, we have the sphincteric function. And that is the one that's directly related to incontinence. Now, if we look at this picture, we have these little, you see there's one little muscle that kind of turns right here, puborectalis. He is very responsible for helping the outer sphincter in trying to control bowel movements. And so we need him to be basically, it bends the rectum so that we don't accidentally lose any stool. We also have these little guys right in through here that are going to help with our urinary system and kind of closing off the urethra. So we need these muscles to be helping us and working appropriately in order to remain continent, as I just described here. So the biggest thing is that, yes, weakness is a very large part of incontinence. And again, I have talked about incontinence. I did a whole lecture on it, so I won't get too into it for those that have already seen it. If you do want to watch it, it's on our YouTube page, and I'll talk about that a little bit later because it is something that I would love for people to know. But the most important thing that you need to know today is that along with weakness or tightness of the pelvic floor, almost everyone has issues because there is decreased coordination of the pelvic floor with the rest of the core canister. So we want everything to be working together really nicely in a piston. So Renee, I should probably stop. Is there any questions yet? Perfect. Okay. So as we kind of think of our nice core canister, the diaphragm at the top and the pelvic floor at the bottom work as a piston, continuously moving, ideally, in order to create proper pressure. So in the perfect world, if you look at little babies, this is what they're doing, is as we inhale, the diaphragm lowers and the pelvic floor will drop and relax. And so what's happening is as the diaphragm lowers, it is creating a pressure in through the abdomen, and you're going to see a belly rise. You're going to see some expansion through there. And in order to maintain appropriate pressure, the pelvic floor will lower with it. That is when we have nice relaxation of the pelvic floor muscles. Then as we exhale, we're now here, the diaphragm will rise back up and relax into its just relaxed state, and the pelvic floor muscles will contract and rise. So as we inhale, diaphragm contracts, pelvic floor relaxes, and as we exhale, pelvic floor contracts and diaphragm relaxes. So it's working as this lovely piston to create the proper pressure in through our core. Then when we have that proper pressure, the muscles, especially transverse abdominis and multifidus, have to respond to that pressure, and we get engaged muscles. This is what creates stability. This is what keeps us upright. This is what allows us to stabilize centrally before we move, before we walk, before we play sports. Now, if we are thinking of that core canister as a pop can, if pop cans are closed and there's no dents in them and you try to crush it, it is nearly impossible. But if you want to crush that can, all you have to do is open that lid and throw a few dents in the mix, and then you can usually crush it quite simply. So we want to think of our core canister in that way. And so if there are dents, we're not going to be able to use it properly. It's not going to be super strong for us. So the dents in the can that we frequently see come from generally 3 areas. We have inappropriate breathing patterns, which is where the diaphragm is coming in. We have inappropriate positioning so that we can't kind of get in the right position, and pelvic floor dysfunction. So I'm just going to talk about those 3 a little bit so you can kind of have an idea of where things went wrong. So when we think of our diaphragm and breathing patterns, again, coming back to if you have any little ones in your life, kind of toddlers or younger, watch them breathe. And they have the cutest little belly breaths. They just expand into these little Buddhas whenever they're napping or very relaxed. And that is because the diaphragm is dropping. And we were all generally born like that. Now, all it takes is one event, usually kind of in our childhood. Maybe you got bronchitis and you're struggling to breathe. Maybe you fell out of a tree. Maybe you got in an accident of some type, or you got hit in hockey funny, and all of a sudden you breathe in through the chest. The body likes to be, it doesn't like hard work. And it is easier for the body to breathe in through the chest than breathe in through the belly, because when you're breathing in through the belly, everything's contracting and creating that piston. When we breathe in through the chest, all we have to do is use these muscles to rise, which the body can usually get away with for a really long time. And we don't even notice until everything else needs to start compensating because we don't have that piston. So a lot of us are in this position where we are chest breathers, especially anyone who has anxiety tends to chest breathe. A lot of people that tend to get tension in through here really frequently. It's could be related to chest breathing as well, because we're lifting here. And so they're getting a little overworked. So when we aren't breathing with the diaphragm isn't able to start this piston process. And so we can have some issues. We're not able to use that core properly. The other one, inappropriate positioning, is absolutely huge. And I'll talk on one specific example, but we see it everywhere. Women who have carried babies. We very, very frequently will see positioning changes because baby is trying to grow. So we'll see the ribs start to kind of, I'll go up, like come forward a little bit. And that is to allow space for baby. We'll also sometimes see the pelvis either tilt anteriorly or tilt posteriorly in order to try and get some support as our center of gravity is moving. So if those ribs are, instead of flat, if they are flared out a little bit, then all of a sudden the diaphragm, if it is even trying to move, is going like this. And so that is not helpful for our piston that should be going straight down. If it's going out, we're not going to get that proper support. So that is one specific example of where positioning can come in. Now, a lot of people can have rib flares. I have never personally carried a child. I definitely have a rib flare. So we see it in men, we see it in a whole bunch of different people, but that is kind of one area where we can start to alter it so that we can actually start to use that diaphragm appropriately. Because if you could be trying your absolute hardest, but if you're not in the right position, it's really hard to use. Same thing with the pelvic floor. If our hips or pelvis, I guess I could use this picture. If we have this pelvis and all of a sudden the pubic symphysis is way up here and the tailbone is way down here, then we're going to be on an angle instead of being nice and flat. It is really hard to use our pelvic floor muscles if they are not in that proper position. So positioning, again, something that probably happens over time, just like our breathing patterns, and we don't notice it until it causes an issue. Now, pelvic floor dysfunction, this is kind of a chicken and egg situation. So if we're already not using our diaphragm properly and we're in a weird position, there's a good chance that we are not able to use that pelvic floor very nicely. So that could be kind of the cause, or those could be the cause of your pelvic floor dysfunction. You also might have had trauma. If that pelvic floor, number one, went through birth trauma and we're not able to rehab, or it was never rehabbed appropriately, you might not be able to use those muscles properly. You might have also gone through a traumatic experience, whether that is violent trauma or emotional trauma, because our pelvic floor muscles tend to be involved in that. And I'll speak on that in a future lecture. But if any of those things happened, then you might have lost that connection with the pelvic floor, or the pelvic floor physically is just not in a good place to be used. So if the pelvic floor isn't working well, then that core canister still can't work really nicely, and we can't get that pressure. We're not stabilizing. Something else has to come into the mix. So it's very interesting, kind of the, again, chicken and egg situation of sometimes one causes the other, but then it comes around and causes it more. And there's so many kind of interrelationship situations throughout the can. So to try and kind of make it really easy to understand, this is sort of one example. So if you have incontinence, prolapse, urinary urgency, any kind of issues down in the pelvic region, then you have some sort of pelvic floor dysfunction. That is where those things are coming from. If you have pelvic floor dysfunction, it means that you are likely not using your piston appropriately. You're not having that proper kind of dropping, contracting, and relaxing throughout the day. If the core or the piston is not working properly, then we're going to have to use something else to try and stabilize. And a really, really common one is the back muscles. Then that will result in the back muscles working too hard. They get fatigued, they get tight, and that results in back pain. So that's kind of one almost flow chart way of looking at an instance where the pelvic floor can be related to the back. Now, it can also go the other way. You can have back pain, which means that you have compensation issues that are coming from not having your core working properly, which results in or leads to pelvic floor dysfunction, which results in incontinence. So it can kind of go in either direction if you're trying to kind of wrap your head around it, but there is just such a strong correlation between the two. Now, what's really important is that incontinence is not the cause of back pain and vice versa. They're very correlated because there's generally the same cause, which is not using the core complex appropriately, that ends up showing symptoms of low back pain and incontinence. I hope that makes sense. I feel like in this kind of situation, that can be a lot to wrap your head around. And so I tried to make it as clear as possible, but definitely a really, really strong correlation between the two based on whether we're able to use that canister appropriately and who is coming in to pick up the slack if we're not using it properly. So all of that being said, I have back pain and incontinence. What the heck do I do? So number one, I cannot stress enough, if you are already getting treatment for your back pain, and especially if it's working, we want to continue with that. So if you suspect that this could be the case, we still want those tissues to be happy. That could be active release, massage, other soft tissue work, stretches. Maybe you're doing yoga. Maybe you're doing a good exercise program. Those are all still very important things, because as you're trying to create changes, you want really nice, happy, healthy tissue. And sometimes this treatment is all that's needed. But I'm never saying that every person that has back pain that's not necessarily resolving needs some sort of pelvic floor work. That is not the case. But if all of these things are happening and you're good, but you're not that great, then sometimes we just need to add on something to that treatment. And so number 2 would be figure out what's going on with the pelvic floor, especially if you have any kind of pelvic floor symptoms. If you have heaviness, if you pee when you laugh, if you have really strong urgency, which is that, oh my gosh, I gotta go right now kind of feeling, all of those are signs of some sort of pelvic floor dysfunction. And it's really, really hard to resolve your back pain if it's compensatory, if you're not able to use that whole core canister. So that's where pelvic floor PTs can help. But that's also where just simply kind of getting involved and figuring out your own body can be really, really important. So once you figure out what's wrong with the pelvic floor, or not what's wrong, what's going on with the pelvic floor, then you have to figure out your core canister as a whole. So breath, are you a chest breather or are you a belly breather? Sometimes both can be okay. Sometimes both can be issues. So trying to figure out what kind of breath you are. If you're a belly breather, are you only breathing into your belly button, or are you able to breathe all the way around? That's going to be important, and we're going to go over that in a moment. Posture. Do you have a rib flare? Like I mentioned, is your pelvis sitting in a funky position? Are you able to actually use those muscles if you're trying to use them, or is your body putting you in a funny position? So you're working on your body, you're working on the muscles, you're figuring out what's going on with the pelvic floor, and you're starting to make connections with that core canister. Then, after we're kind of in touch with what's going on, we start an exercise program. So you want to have some sort of creating that connection between the pelvic floor and the rest of the canister. That is key. And something my back patients on one side of the clinic are going to be doing, that's something that my pelvic floor patients are going to be doing. Everyone needs to be trying to create that connection with the rest of the canister so that everything else can relax. Then, once you make that connection, you start to actually activate that core, use that core appropriately. There's a long kind of exercise progression that people will go through with different positions and kind of stabilizing centrally at their core, and then being able to move their arms and legs so that the brain can actually make that connection of, oh, I do this in normal circumstances and not just when I'm thinking about it. You also want to be doing some sort of pelvic floor work. So for those that are super, super tense, you're going to have a relaxation routine and a stretching routine. For those that are super, super weak, we're going to have probably some sort of strengthening, endurance, fast and slow routine. Usually those are all going to kind of go together as you go forward. Then you're able to get to the fun stuff. We're going to move you from being on your back to being in sitting to being in standing. Then looking at moving around. Can we do squats while having control of everything? Can we, or sit to stand even? Can we walk around? And then most importantly, get you to the activities that are actually being impacted in the first place. If you are somebody who hikes a lot and you're having back pain and some incontinence issues, we want you to be able to hike. If you ski, if you golf, and every time you rotate and hit the ball, you notice some incontinence and you have back pain at the end. We want to care about golf. So your exercise program is super, super important once you figure out what the heck is going on so that it's actually going to be related to you and your life. So let's start right away. This is usually what everyone's here for. What can we do right now in order to at least get the ball rolling? So again, sorry to those who have been my patients. You've probably done this before because I love for everyone to do it, but I really encourage everyone to follow along with me and let's see where we can go. So we are going to figure out how we're breathing first. Now, if you are sitting, sit comfortably, bring your back against the backrest of your chair. Make sure that both feet are on the ground. If that's not possible, I'd rather your feet be on the ground. versus back against the backrest. But if you can do both, that's great. Try to have equal weight bearing on both sit bones. And then if you want to, you can also lie down. This is usually where I start people in clinic. And so you're going to be lying down on your back, head on a pillow maybe, or just flat on the floor. Generally, most people, it's going to be bent knees, feet flat on the ground. If that is not comfortable, you can always extend your feet. Everyone is a little bit different, but that is usually where I'll start people. Then once you're in that position, you're going to place one hand on your chest and one hand on your belly. Feel free to close your eyes so that you can kind of feel what's going on and you're not distracted. And we're going to take a breath in through the nose and exhale through the mouth. And I'm just going to have you continue to breathe in through the nose, out through the mouth. And right now we're exploring, we're figuring out what's going on. And I want to know, where does your breath go? Does your hand on your chest tend to rise? Do you feel your shoulders rising up towards your ears when you take a nice inhale? Does the hand on your belly rise at all? Are we able to modify that or change it on a whim? Right now, we're just kind of exploring, seeing what's going on so that you're able to figure things out as we go. So I'll let everyone kind of take a moment, take a few breaths there, figure out what the heck is going on in your own body. All right. Then we want to try to start to draw the breath down into the abdomen. So we're trying to encourage the diaphragm to lower instead of the chest to rise. So for some people, simply thinking of the hand on your belly is enough, and that's great. You can start to breathe, try to breathe into that hand right on your belly. For other people, sometimes we need a little bit of imagery work, and we're going to think of the breath being drawn into the windpipe, down beyond the ribs and into the belly and expanding from there. And you'll take a few breaths and just see if you can start to kind of get control of the situation. Now, if you are really struggling to get the breath down into the belly, we might have to alter your rib position. Now, this can be a little bit tricky, and usually I do it for people, but if you're really struggling, think of bringing your ribs, if they are out, bringing them down a little bit. And that's we're going to shift our whole rib cage down, almost leaning forward. We're not pulling it down with our abs because we want our abs to be nice and relaxed. They're loosey-goosey. We're shifting the whole rib cage forward a little bit and see if that helps. You're still keeping a hand on the chest and trying to reduce that movement. And then hand on the belly is where our breath is going to go. Now, for a lot of people, that is tough enough. And if that is the case, you keep breathing, get in touch, and just simply try to bring that breath into the belly. If this is going really well for you, then it's really important that we start to expand in all directions. Again, especially for women who have carried children, or any men who have had separation of the abs, or anyone in general who's had separation of the abs, the pressure is going to want to come straight in front, right through the belly button. And we don't want that in order to create this core pressure. We actually want to expand in all directions. So if you're doing well, then you're going to bring your ribs down to your your hands down to your lower ribs, fingers in front, thumbs behind you, and you're going to give yourself a little squeeze. And then as you inhale, you want to see if you can inhale into your hands, creating a small expansion. What's nice is if you're focusing laterally or focusing into those hands, then you are going to naturally expand out front. So you don't even have to focus on that anymore. Just focus on breathing into those hands. We're never pushing, because that's just not very helpful. We want it to be a really passive expansion. Then if you are doing swimmingly at that point, then we're going to start to focus on going into the back. So we want to breathe in all directions. This is the bread and butter of getting those back muscles to relax. So if you're against a chair, think of breathing into the back of the chair. If you're on the ground, think of breathing into the floor. And that might be something that you want to try later as well. And so you're trying to expand in front, out the sides, and into your back. If you are able to do that, you are going to create pressure in through there. We're going to have proper core engagement, and those super tight back muscles that we talked about, the ones along the spine and the ones that are going on an angle there, can actually relax. And for some people, they haven't relaxed in years. And so this can actually allow you to get in touch and basically take control of that relaxation response. So I encourage anyone, whether you have pelvic floor issues or not, at least try to do this every once in a while to give yourself that opportunity to get the diaphragm to drop, see if we can engage the core a little bit, but most importantly, allow those back muscles to relax. Now,
sorry. Can I ask a quick question on that? Would you say a 5-minute exercise of that would be sufficient, or what kind of timeline would you?
Absolutely. Fun fact, they recently, in the last couple of years, realized that breath work helps with our autonomic nervous system, which is our fight or flight response. And in order for breath to actually help with our fight or flight response, we need 5 minutes. So for most people, I encourage you to try and go for 5 minutes in order to get the physiological, just like in control of the diaphragm, you can probably get away with 3 or 4, but to get the biggest bang for your buck, 5 minutes a day can make a world of difference in being able to use these muscles appropriately. Excellent question.
Okay, thank you.
Now, if that goes well, we want to connect with our pelvic floor. And this is one area, and most people that I see, even most friends that I talk to, we haven't thought about our pelvic floor potentially ever, potentially since a traumatic event, maybe since birth. A lot of times we have no idea what's going on down there, and that's okay. But we want to bring our focus back to the pelvic floor so that we have a little bit more control over it and we can bring it into that core canister. So for right now, since I don't want to create anything, we don't want people necessarily contracting if they're tight or relaxing if they're loose, but just kind of getting in tune with that area. We want to see if we can feel the pelvic floor relax with an inhale and then return to neutral on the exhale. Most people won't feel the exhale unless we're actively contracting, but I want to see if you can actually feel the pelvic floor relax with the inhale. For those that are sitting, if you have like a little sweater around or something, you can stick that right under your perineal region. And it just kind of brings the focus there. If you're lying down, you're simply thinking of that area, close your eyes and just see if you can feel anything happening. Can you feel that pelvic floor relaxing as you inhale, a nice big inhale? If you can, that's phenomenal. That means that it's going to be so much easier for you to get in touch with that pelvic floor and either strengthen or relax or whatever you need to do, and start to get that core canister working again and being used with that diaphragm. Now, if you are struggling to feel that, we can add a small contraction in order to feel the relaxation. This does not mean go after this and do a million Kegels. That might not be appropriate for you, so that is not what I'm recommending. I just want everyone to be able to see what the pelvic floor can do. So I encourage you to inhale and relax that pelvic floor. Never push out, just relax. And as you exhale, do a little squeeze and lift. For the women, think of a little ping pong ball at the edge of your vagina, and that you're just kind of bringing up into the vagina and then letting go. For any men that are with us, you can think of basically, we call it pulling the train back into the station. So if you think of the penis, we're trying to pull it back towards the body, or you can think of kind of lifting that scrotum up towards you is another way to do it. So we're trying to kind of squeeze and lift on the exhale and then relax on the inhale. And this is something that I encourage everyone to do a little bit later when you have a moment, and just see if you can feel anything. And if you can, that is wonderful. It is not meant to strengthen the pelvic floor right now. It is not meant to relax it in any way. It's simply getting in tune with it. And this is one of the best ways to do it in a really safe and healthy way. I should caveat that with, if you have experienced trauma, your brain might not be ready for this, and that's okay. So if you are struggling to feel that connection, there's probably a lot of layers and it's just not ready to go yet, and don't push it and don't feel stressed. But if you can feel it, then this is a spectacular way of gaining control of this area. So inhale, pelvic floor relaxes as the diaphragm drops. Exhale, pelvic floor returns as the diaphragm goes back up and relaxes. So that exercise is something that really everyone should do on a general, regular basis, even if the pelvic floor isn't involved. Just simply getting the breath going. Lying on your back is ideal. Sitting is also an option. It's just a little harder. And always trying to breathe into your back. And so you can actually let those muscles relax. So to summarize, the core, or our core canister, is made up of the diaphragm on top, the pelvic floor on the bottom, transverse abdominis on the front, multifidus in the back. It is not related to our six-pack muscles. So you can do a million crunches if you want. That's not going to help with your general core strength. The diaphragm and the pelvic floor work together as a piston, creating that pressure, maintaining that pressure, creating activation so that we can stabilize centrally before we move our arms and our legs. If our core canister has any dents, that being not breathing properly, positioning issues, or pelvic floor issues, then we can't stabilize properly, which creates compensation. That compensation is generally seen in the low back with those muscles that are along the spine and kind of on angles along the back. And that can then affect our ability to, well, not feel pain, but use the body properly as a whole. And it can also affect our ability to use our pelvic floor properly. Now, the biggest thing, if you're going to take anything from this, is basically that if you have back issues and some sort of incontinence or pelvic floor issues, there is likely a central stability component, and that can be rehabbed. That can be something that you can work towards fixing, which would just be phenomenal. And when we consider how often these things can affect our lives. So that is kind of the end of my presentation. I'll ask for questions in a moment, but I do encourage anyone who wants to, please reach out. The reason that I do these talks is so that people can know this information. It's all things that I experience with patients and things that I really want the general population to know so that they realize that things can be fixed. So please reach out if you have any questions. The clinic number is there. If you feel like you want an appointment, that's great. If you just want to talk to me, you can always call the clinic and I'll call you back whenever I get a chance. That's also my personal work email. So feel free, anything that you email me will remain completely confidential. So give any details that you want, and it is just between you and me, and I'll answer to the best of my ability. Sometimes the answer is, unfortunately, I don't know until I assess. But if it's a quick and easy question, I have no problem answering it or guiding you in any way. Please also feel free to, you're going to get a link to this presentation, send it to anyone you want. That is me simply wanting the more people to understand this part of our lives. It is not a marketing tool of any type for me. It's just more people that know this, the better, so that back pain and incontinence stop being a problem for most people. Now, I did do other lectures previously, and they're on the YouTube page. And I kept talking about the YouTube page to people, but I had no idea what our page was actually called. So I know now it is Active Sports Therapy 1. And I did one on incontinence. I also did one on prolapse. And I really encourage people, if that is an issue, listen to the lecture so you at least kind of have some idea of what's going on. And then I have no problem answering any kind of questions. So on that note, are there any questions right now, Renee?
I think I just saw a new one. Let me, for some reason, my question box has shrunk to new messages. Yes. Yeah, just a couple thank yous.
Thanks, guys.
Yes, thank you, Ellen, for your knowledge and your passion to deliver this information at a bigger level. I think it's so important. And yes, it's every session I've sat in on, I'm learning so much. So thank you. Does anyone in the community have any further questions that they'd either like to unmute and ask personally or just type into the chat? I'm not seeing anything as of yet. I did want to mention that there was a question earlier that was linked basically asking where can we watch the previous videos. And yes, Active Sports Therapy does have a YouTube page. It's relatively new. That's why it was harder to find with the Active Sports Therapy one. Ellen's done all her research, so it's there. You will be receiving a follow-up email with this lecture, along with a link to the last two on the YouTube page. So you can always go and watch the other ones at your convenience and pass them on, let your friends know. I think this is so important. And also, I think there's some privacy with men. Like every time I learn about this, I'm like, there could be a lot of men out there that, you know, are kind of suffering in silence on the side with a few things that they would never think to join one of these sessions on. So if there's any men in your life, it's worth having that conversation. So stay tuned. We do have a pelvic floor lecture coming up. I'm guessing in January. We haven't committed to a date. Okay, the date will be announced in the January newsletter. There is a new link to every session. So look for the January newsletter for all information on the date and the time. The topic for the lecture in January will be the protective pelvis and how trauma affects the pelvic floor. So that's going to be a very interesting one. I look forward to that. As Ellen said, feel free to call in the clinic, have a chat with Ellen, or book online. You can always book online in our booking system if you are an existing patient.
Actually, you cannot do online bookings for pelvic floor, just so everyone knows. Yeah, and it's just because we're in massage rooms and there's specific hours. And
okay, this is good to know.
There you go.
Okay, so call in for the pelvic floor sessions.
Yes.
With no further questions, I just want to say thank you so much, Ellen, for this one more time. And thank everyone for your time. Hope that you've had a cozy, informative evening. And we really appreciate your time coming to listen to this lecture.
Yes, thank you so much, everyone. Have a lovely evening.
Bye, everybody. Good night.